What is up, everybody? Joshua Smith here, and we are here with another Ask Jim and Jay episode hosted by me personally, Joshua Smith. So we release this information. This show exists, and we've created this show to go out there and drop the right information, a lot of great knowledge on you guys so you can go out there and level up inside your health, fitness, nutrition, and overall optimize your health and your body and take it to the next level. So real quick before we jump into today's show and today's content, I just want to give a quick plug to Jim and Jay's newest book, which is the Metabolic Blowtorch Diet. So this is an advanced strategies intermittent fasting program that allows you to go out there, maintain muscle, even gain muscle mass while shedding off and stripping off that body fat. So this diet is absolutely insane. It's what Jim and Jay and even myself now personally am on. This book is free, right? So Jim and Jay are given a free copy. You just got to pay for the small shipping and handling fee. But if you go to metabolicblowtorchdiet.com, so www.metabolicblowtorchdiet.com, you can go and get your free copy today. So make sure that you go check that out. All right, you guys, let's jump on into the show. What is up, everybody? Joshua Smith here with another Ask Jim and Jay podcast show where every single week we come at you guys with important topics and great content that can help you level up every aspect of your life when it comes to your health, fitness, and overall longevity. So today, guys, we are joined by a very, very special guest. We've got here with us with Jay and I, we got Dr. John Crisler, who is one of the leading testosterone replacement therapy doctors in this space. I mean, this guy's been doing this for a lot of years and is one of the best physicians on the planet at what he does. So really stoked and honored to have Dr. Crisler here. Welcome to the show.
Thanks, Joshua. Glad to be here. Hi, everybody. Happy Valentine's Day.
Yep, that's right.
7 o'clock here. I love you guys so much. I'm spending my Valentine's night.
Thanks, man. You're the man, dude. That's why we love you, brother.
It's an honor, man. So, Jay had sent me some talking points to go through here. But, before we get into some of these questions, you've been doing this for, several decades. And so I'm sure that you've seen a lot of the decline, in men today and the more demand for the need of testosterone replacement therapy. And, a lot of our guests, those that follow Jim and Jay very heavily, are very educated on this topic. But a lot that follow my space are entrepreneurs that are being introduced to this, since Jay and Jim started talking about this very heavily when we started this podcast. We've got a lot of new people that are being introduced to this. Can you just, talk about the importance now and why it's so important today for men to be paying attention to their testosterone levels and the impact and differences that you're seeing in your patients' lives?
Sure. Good question. Good topic. Well, basically a man's body runs on testosterone. So when there's not much gas in the tank, there's not much to run on. It's very clear that when a guy's hormone levels are up, he feels good and he's healthy. And when they drop down, he becomes unhealthy and unhappy. And then we put him back up again. He usually returns to his previous state and maybe even better because a lot of guys get tuned up better along the way than they were when they started. So as hard as this life is, you just don't have a chance if you're going through it with low testosterone as well.
Yeah. And it's one of those weird things, it seems like, women, the norm is they hit a certain age and they naturally get treated for hormones and balance, but this is just kind of like a new thing for men. And I know when I first met Jay, I'm 33 years old and hard driving entrepreneur, but I'm as healthy as I can take it, eating fully organic and working out hard, but I still was missing something. And, when he first brought it up, my mind instantaneously went to steroid abuse, right? I'm like, hell no, and it took about 6 months of wearing on me, me to get open-minded to it and then say yes. And it's been such an insane game changer. So love it. All right. So, one of the things, and one of the talking points here, and one of the things that is we're seeing talked about more and more and more is HSBG, sex hormone binding. What's that?
Globulin.
Yeah. So I always got to have these guys help me and correct me. I'm just the patient, right? I'm not the expert like you guys. And I know when I first had mine tested, they're like, oh, you have a high level of sex binding hormone. I'm like, hell yes. And the doctor's like, well, that's not necessarily a good thing. I'm like, damn it. Right. So can you elaborate on what it is and why people need to pay attention to and why it's important?
Great. Well, first place, good thing your doctor is testing it because a lot of them aren't. The sex hormone binding globulin is a centerpiece of every appropriate sex hormone evaluation. You've got to know what it is to know what's going on. Also, direct your care, and it also explains a lot along the way. If you ask whether low sex hormone binding globulin or high sex hormone binding globulin is better, first we got to talk about what it does. Is sex hormone binding globulin binds sex hormones, so everything from DHT down through testosterone and even estrogens are bound up. Once it's bound to the sex hormone binding globulin, it's not inert, but we have traditionally treated it that way. We've learned a lot more about it now. We find that the sex hormone binding globulin sex hormone complex actually has a lot of activities. I'll get into that in just a second, but basically the lower your sex hormone binding globulin is, the higher your free testosterone will be. Of course, at the same time, then the higher your free estrogen will be, so it's a double-edged sword. I guess when you consider the declining testosterone as a man ages, he produces less and less testosterone. The lower his sex hormone binding globulin, the better off he will be, because the easier it will be to get up over the top of it to still have enough free testosterone left over. But we're learning now really that sex hormone binding globulin at lower levels seems to predispose guys to anxiety. It's very rare for me to have a patient present with anxiety issues and a high sex hormone binding globulin. I haven't known it a few times. And you'll have outliers in every situation in hormones, because it's just basically is like walking on slippery rocks all the time. It's just a kind of a weird world to work in, including the laboratory testing. But there are two things that sex hormone binding globulin does outside of the cell without even getting into the cell. One is to bind the sex hormones, as we just talked about. Also, sex hormone binding globulin, about 20% of it is floating around free in the blood, can bind to its own receptor on the cell membrane. Once that happens, then a testosterone or an estrogen can bind to it. And that they both, testosterone and estrogen, then trigger the same mechanism inside the cell. So there is a vote for higher sex hormone binding globulin being better for you. On top of that, we now know that the sex hormone binding globulin and sex hormone complex can actually enter the cell. We see sex hormone binding globulin inside the cells. Also, some cells produce sex hormone binding globulin inside, so we're wondering if maybe that has some effects inside the cell, maybe on its neighbors or whatever. And sex hormone binding globulin has its own androgenic or male-like qualities to it. So there's four things we've identified so far that sex hormone binding globulin does. The reason this is important is because it begins to explain the tough cases for us. Guys come in, everybody wants their sex hormone binding globulin low because they want more free testosterone. But then again, they have higher free estrogen, so that can be a problem. Some of these guys with lower sex hormone binding globulin can hardly tolerate any estrogen at all if it's too high for them. So if a guy is not on testosterone replacement therapy, it's probably better if his sex hormone binding globulin is lower. The problem with that is that usually is a sign of inflammation in the body, and we all know that all chronic disease is related to inflammation, whether it's heart disease or cancer. So that sign is a sign of his inflammation in the liver and so forth, because that's where most of the sex hormone binding globulin is produced. Once he's on testosterone replacement therapy, it's probably better the sex hormone binding globulin is higher, because I can always give more testosterone and get up over the top of it. And again, we're seeing these positive benefits from sex hormone binding globulin. There are more and more coming in now. If you have a guy who comes in with low testosterone and high anxiety, it can be a really difficult case to treat, especially if the guy wants to use a gel, because for some strange reason, again, this is just the quantum nature of interventional endocrinology, but for some strange reason, the high variability that you get with testosterone gels and creams, which is usually a good thing for a man, the more variability, the younger you are. But these guys seem to have a harder time tolerating a gel or a cream, so it's going to be shots for them, and most often 2 or 3 shots per week, because the lower your sex hormone binding globulin, the more you're actually excreting it into your urine. In the old days, when we gave very large doses of testosterone every 2 or 3 weeks, it's a very strange thing, because the doctors never considered the half-life of testosterone. It's the only area of medicine where doctors never think about the half-life of drugs. Giving these huge, massive doses every 2 or 3 weeks, the testosterone would shoot up so high, the body would start trying to get rid of it by dumping it into the urine. Unfortunately, it doesn't do the same thing with estrogen. So these guys need twice per week shots, sometimes 3 times a week. Some guys want to do them every day if that's their commitment to their health and fitness. My hat's off to them, but it seems like a lot of fiddling around to me. But these guys need more frequent shots because basically they're peeing it out about as fast as coming into their system. So that's why you really need to get with somebody who knows what they're doing for their testosterone replacement therapy to direct your care.
Do you have anything that you wanted to add there, Jay?
No, I mean, the problem with sex hormone binding globulin, as John says, is that most physicians are not measuring for it. I mean, this isn't going to be a topic today because we got a lot of stuff to talk about to go down the pathway of like why so many physicians aren't, because we could go really down a deep rabbit hole. But I mean, the issue clearly is Nelson and I just did a podcast last week that if you're not getting the right panels evaluated before you start, and even obviously during, you've got to work with a physician who's going to do this right, because the chances of you being screwed up when you're not working with someone who's familiar with this is high. Right, Doc?
Sure is. But God bless them for prescribing testosterone replacement therapy in the first place. At least we won the hearts and minds battle with them to get them moving. Now we just got to get them trained up on it. That's what we're trying to do.
As you always say, you're training them as fast as you can, right?
Yeah.
Yes, sir.
Yeah. And that's where my mind was going, as you explain this in depth. It's because this, science and we're learning new things so fast. This is the importance of watching and listening, is making sure that you're working with a great physician that is studying this at a very high level. So many don't. And if they're not staying on top of this, like what worked 5 or 10 years ago may not be what is most effective. And this is the thing, like you talked and you made a joke about, doctors prescribing one or two, or one shot every 2 or 3 weeks.
Right.
I just spoke to a friend of mine who's an entrepreneur. His doctor has him on that protocol right now. He goes in every 3 weeks for one shot. And, we're still seeing that kind of stuff. So, and we'll have them below, all Dr. Crisler's information. So those of you guys, again, that need a great doctor, it's important to work with the right doctor. So, you talked about anxiety there. And this is something that you hear once in a while from those that are on TRT that, seems to create more anxiety. Is it just because of the sex binding hormone, or is there other things that potentially can create the anxiety?
Well, that is a huge topic. Anxiety is one of the most difficult things to treat in all of medicine. And we try to stay away from the anti-anxiolytic drugs, the benzodiazepines if we can. In the excellent podcast that Jay did with my old friend, Dr. Rob Kumini-Eric, you talked about putting guys on testosterone replacement therapy and have it just wire them up. It just makes them go crazy. And it boils down to a lot of these cases. Number one, Dr. Kumini-Eric brought up giving magnesium. Right. And we're finding now in hormonal optimization, if something is weird and is not right, go to magnesium. I take my guys up to about 800 milligrams a day. That's true for men and women with all the hormones. Right. And magnesium just seems to be the answer in a lot of these strange cases, and it's practically free. Also, it's great for lowering blood pressure. It's great. About 80% of the people have so-called restless leg syndrome, which is a fabrication of a marketing agency. Jay and I have talked about that before. About 80% resolution with magnesium. So do that. Some of these guys are just being started on too high of a dose, especially the traumatic brain injury patients I'm starting to work with now through Dr. Mark Gordon's Millennium Clinic. Right. Is that these guys, they need to be on 60 milligrams a week, not 200. So they're being started on a couple hundred milligrams a week. It's just too much for them.
Too high, right.
But also sometimes guys, you put them on testosterone replacement therapy, and a year or so later, they feel great at first. A year or so later, they're not feeling so good anymore. It's time to tune them up again. What's really happening there is this absence of what I'm calling backfilling the pathways. You shut down the whole system when you give testosterone. So if a guy had primary testicular failure, where his testicles just aren't responding and producing testosterone, which is less than having secondary failure, which is where they're not getting the signal of luteinizing hormone, produce testosterone, is that you're inducing secondary hypogonadism by giving testosterone replacement therapy. So that whole pathway is disrupted now. So we give back in the pregnenolone, we give back in the DHEA. We like to use HCG on a regular basis. Start those pathways flowing back up again. These guys just do better. Why? Because it's a more natural state of being. There's supposed to be just a few steps between cholesterol and testosterone, but the fact of the matter is we'll really never know about all the little places where it's working in and out and so forth. For instance, we really don't have any receptors for DHEA, but everybody knows that DHEA increases libido and does improvements in cardiovascular health. Immune function is very important for the brain. And protecting the brain, of course, is central to all medical therapies. So, once you start to get those pathways flowing again, they just plain feel better. So a lot of guys come in, they've just been on testosterone. I start them up on HCG, DHEA, maybe some pregnenolone, especially if they're having anxiety. And it's night and day for them.
Yeah, it is crazy with this stuff of, so many people think with anxiety, people that suffer from anxiety, it's just like, hey, they just don't know how to handle stress in life and deal with, these outside stressors, right. Like you're saying, I mean, you're discovering that so much of it is hormone related.
Yeah. Well, the problem when the pathway is shut down is something called allopregnanolone is reduced. It is produced, which is reduced from pregnenolone. Allopregnanolone is the body's own natural benzodiazepine. It's the body's own natural Xanax. And so when you give testosterone, this is what happens over time, is that the allopregnanolone goes down. That's why I like to give pregnenolone 50 milligrams, hopefully in sustained release at night before they go to bed, and then maybe another one in the morning. That converts to allopregnanolone in the liver. That's why we'd like to take it orally. Crosses the blood-brain barrier and goes in the brain, and the more the pregnenolone goes in the brain produces its own allopregnanolone. And so the problem when you're putting guys on testosterone replacement therapy and not backfilling the pathways is that allopregnanolone goes down. So if you give it in the form of pregnenolone, which is a standard treatment in the United States in the 1930s and 1940s for adrenal insufficiency and anxiety and depression and so forth, before all the pharmaceutical drugs came out, it worked really well. We get really great results from it. It's something you can get at the health food store. So although I recommend a compounding pharmacy because it's you need USP grade, laboratory tested product.
Now, when it comes to that, are you finding the same thing to hold true for women? Like, as an example, several years ago, my wife has just kind of went cold turkey and she's total anti-HRT because she did experience a lot of anxiety when she went on this. She felt worse, but the doctor that we were working with at the time, which we no longer are, but she went down, like she got he didn't do any of the things that you're talking about here, and she just got a bad taste in her mouth. So do you find that to also impact women kind of in the same way?
Well, I encourage her for herself and for you to get with somebody maybe perhaps a little more experienced. Anxiety is common. I don't know where she is in her life with respect to her. I don't know how old she is, and we probably shouldn't tell, especially on Valentine's Day, but
35.
Mid-30s, man.
Yeah, 35.
She probably needs progesterone because that starts to drop at about 30 years old. And we're talking small doses, like 12.5 milligrams. And then dosing up from there, that can be like night and day, literally.
I think she's going to be working with Meehan. So Meehan learns from you, John. So I'm sure she'll be okay. But I want to make a comment about stress and anxiety. And obviously I'm going to be a shill for the book. Anxiety comes from there's a million medical reasons, and John's already hit all those too. But I find that most people have anxiety because they do not silence the mind. There's no meditation. There's no inner work. Josh is a big meditator. I'm a big meditator. I feel like if you can teach yourself, and anyone can learn to meditate. It's not hard. It's not like sitting like a yogi, outside in the wilderness. To silence your mind, you can pretty much overcome, because a lot of this is fear from the media, from the bullshit, the fake news, the nonsense in the mainstream that tells people that, using hormones is risky, scary, as John knows, all the, bullshit side effects that it supposedly causes, which we've completely refuted and destroyed in the book. But yeah, I mean, a lot of this is just because people are really, truly anxious over doing something that they feel judgment from, right? Their friends might judge them. Their parents may judge them. Their peers may judge them. Anyway, I mean, Josh, and you know this, John, and this is, I think, a good topic for John to answer, but how many guys have you had come into your office and say to you, hey, doc, this has to be between me and you. I can't allow anyone to know that I'm doing this. I mean, it's a joke. In this day and age that we are still fearful of optimizing our hormones. I mean, I get guys calling me since the book launched. I had an A-list, I won't mention his name, but literally an A-list guy today texted me and asked if I could talk to him. So I said, sure, you're an A-lister. And he literally, that's all it was for 5 minutes. Listen, I cannot let anyone know that I'm doing this, blah, 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 blah. And I'm just like, it's just, why are we still in this world where people literally think this is wrong?
Well, probably the influence of those steroid days, unfortunately.
It's crazy.
But, we just got to keep pushing.
Yeah.
I love John is a man of many words on this. He's like, he always is like, Jay, I've said this to you before. We just got to keep doing it.
Yeah.
I'm training him as fast as I can.
Now, what Jay always talks enough for all of us, so we're good there. So, and I agree with you, Jay, to an extent, right? You obviously meditator, but like with my wife Amanda, she meditates way more than I do. And when she, like right now, when she's not on hormone treatment, this is something that she's never like really suffered from. But as soon as she goes on, right, she experienced that anxiety. And she was totally cool with it. It wasn't a fear of being on HRT. There was something else going on there. Because then when she got off of it, and they all entered, exit her system after about 8 weeks, then it all went away. So I think that there's a lot to what Dr. Crisler said of, some of it might be, mental and things to help there. But I think there's a big medical component too.
No, I believe that 100%. I mean, there's no question something's imbalanced for sure.
Yep. So then, brings us to our next topic, which is AIs. And, I would say like with Jim and Jay's new book, I mean, this is, something that they really hard on here inside the book. And, they're in the camp of only being on AI if there's a true medical clinical need. And you're seeing so many physicians that just combine it out of the gate instantaneously, no matter what. And, I'm just going from what I learned from Jim and Jay of the negative long-term side effects to an AI if it's not needed, like, the bone deficiency, breakdown and other things. Where are you on AIs? I mean, is it something that everybody should be on if they're on testosterone, or just something you should check for on case-by-case basis?
Excellent. Well, what really has interested me is in the past couple of years is a lot of my colleagues, doctors who I know personally, I respect tremendously, I like a lot, my dear friends and colleagues, are talking about anastrozole as if it's some kind of a poison. In fact, one colleague of mine said on stage that giving a little anastrozole is like giving a little poison. And that really surprised me.
That was Dr. Neil, right? That was Neil, right? That was Neil.
This guy is really, really smart. And it just amazes me. So I just we lead off by saying no one ever said to lower estrogen too far.
Right.
There's no question that's bad for us. It's really bad for the brain. It's really bad for the bones. It's estradiol that inhibits the breakdown of the bones. Bone mineralization is a dynamic process. Always laying it down, always picking it up. You want to be laying it down good, not picking it up and carrying it away. It's bad for the lipid profile, really bad for the cardiovascular system to drop estrogen too far. So they present all these studies on stage. And I look at these studies, and the first thing is, you look at the study, we see the laboratory methodology they use for the testing during this course of the study is bogus testing. It's the old immunoassay testing. If it's not liquid chromatography mass spec, it's got to be a sensitive assay or TMS as they call it, or enhanced estradiol, Mayo Clinic calls it. Then you have to throw the study out.
Yep.
And these opinions are based on these studies. Second thing is that
Well, hold on, John. Let me stop you. I want to ask you something there because it's a good question. It's a really good point. And this is never covered, and I know you know the answer, so I'm asking you. How effective are the previous studies from a measurement of E2 levels? Like, what would you say the error ratios are, or the margins being off? I mean, are we talking more than 50%?
You can't trust them at all.
At all.
Too many things are what I call the false prophets. They look like estrogen to the immunoassay test. C-reactive protein factor, progesterone sometimes, all kinds of stuff looks like estrogen. So what happens is the guys have a high number on their estrogen. He may not be having any symptoms of high estrogen. And if you don't have high symptoms of estrogen, I don't treat. The guy says he does not feel high estrogen, I do not treat it.
Exactly.
There's too much we don't know about this.
So what does the guy say to his doctor? I need this is going to be a great answer. But what does the guy say to his doctor who's on a managed care doctor, and the guy's not a John Crisler, which is 90%, 95%? When they want to go down the bullshit pathway and get this bullshit test, like how does he communicate to the doc and say, Doc, you don't understand, I need a sensitive liquid C test? What's the best way for him to say that?
Well, not only do they have to do that, they also have to do it with a lab tech, because I put the code right on there for the lab techs. All the time it comes back, they've changed it from the right test to the wrong test. It drives me nuts.
But why is that? Because it's more expensive and they're trying to minimize costs? They're just trained rats? That's
one thing. Yeah, a laboratory director for a system local here had an argument on the phone with me that the LCMS was not necessary because it cost him more money. And I said, we're talking about patient care. That ended that conversation. I directed him to my friend who was the laboratory director of the Quest Diagnostics Nichols Institute. All of Quest knows this. So why this particular director at this laboratory, this hospital system doesn't, is beyond me. But again, if you don't have symptoms, don't treat it.
Right.
Because everybody's got their own sweet spot. Some of these places are putting guys on aromatase inhibitors to lower estrogen based on the wrong labs. Some are just doing it because they want to sell drugs. So that's bad too. But the problem with a complaint about low estrogen hurting the brain is that the aromatase inhibitor, like anastrozole, doesn't cross the blood-brain barrier. And the brain thinks so much. That's the real kicker right there, because the brain thinks so much of estrogen, it makes its own. Right. So testosterone gets into the brain, right. And if there's not enough estrogen with it, the brain will make its own. The aromatase inhibitor is not there. Even the doctors who I should say, a portion of the doctors who are against aromatase inhibitors and talk about them like they're poison, they'll use, for instance, high-dose zinc to lower estrogen.
Right.
All that cell knows on the other end is whether it's seeing estrogen or not. The cell in the brain, the cell in the bone, it does not matter whether aromatase inhibitor is on board, just the concentration of estrogen. And sometimes the particular type of estrogen, there's about 40 different kinds of flavors of estrogen in the body. So the spread of estrogens of the panel can be important. But if it's not like using a selective estrogen receptor modulator like clomiphene or tamoxifen, which is going to act like estrogen in some tissues or block estrogen in others, where it's actually acting on those cells itself. Right. All that cell sees is the concentration of estrogen, whether it's in the brain or in the bone. So it really doesn't matter. So the guy comes in and he's swollen with water. He's got nipple issues, itching, burning, swelling of nipples. They say that a common phrase I word here is they feel bloaty. And if you've ever had it, you know what it feels like. They're just not right. Right. Depression, lack of erectile quality, right. Lack of libido. You put him on a little bit of anastrozole, and all of a sudden he's peeing off a couple quarts of water. All of a sudden it's picking him up right away. His chest, his nipples don't hurt anymore, and his erections get much stronger. So that's really where it is with that. Well,
let's stay here because this is really good, and you've really provided some amazing stuff here. I mean, this is some next level stuff. I'm just going to say next level shit because this is get shit done mode group, right, Josh?
That's it.
But guys, so I want to recap what John just said. Okay. So we have 75 to 80% of the community is literally taking estradiol tests that are worthless. And then we have probably 70, and again, I'm just estimating, I'm just playing here on this broadcast, but then we have 70 to 75% of the physician prescribing community relying on bogus testing methods to measure estradiol and across the board writing a script because, like you said, they're trying to make money for something that they don't even have symptoms on. I'm talking about most guys initiating therapy, right? Like the low T clinics, the doc in the box places. So it's like when you really think of it, what John just said, there is a need for an AI, right? But in reality, it's not, because when Dr. Rob and I won't name your other good friend who we know, talks about
actually you know several of them.
Yes, but when we talk about them as cancers, we have to be very careful because you're right. The truth is these guys are not being evaluated correctly due to blood work and due to physicians who are afraid, which we haven't brought up, John, which I want you to talk about, being sued by some idiot who calls them at 3:00 in the morning and says, "Doc, my nipples are itching."
He clearly needs a aromatase inhibitor. So these doctors that are on stage and lecturing and calling aromatase inhibitors poison, I just put it out there. Show me one study where appropriately dosed aromatase inhibitors hurt anybody. Show me just one study. In fact, show me one study where they use an appropriate dose of aromatase inhibitor. If they're out there, I haven't seen them yet.
Well, that's another great question because there's no appropriate doses. The average guy out there in the doc in the box places is literally hitting guys with 1 milligram 3 days a week.
Wow. Well, if you're giving 4 to 8 times the dose of a drug you should be, of course you're going to show me any drug you can give 4 or 8 times too much where it's not going to hurt you. Right. So all these studies are using, a milligram a day or something like that. That will trash almost everything. I have a few patients that take a milligram a day. They're huge estrogen converters. Like I have a few patients who are big hyper responders to anastrozole. They take 0.1 milligram every other day for something. It's just a variability in the bodies. That's why you need to customize your care for everybody.
Well, I won't mention this person's name, but you and this person have gone back and forth on Facebook in various groups, and also a brilliant physician and very successful and well known. But I mean, the guy literally gives guys 1 milligram to start off with no labs to represent it. So again, no, we're not here passing judgment, but your points today, just to recap, are very, very, very shrewd. And that is, the majority of testing is bogus. You can't go by the testing. It's not liquid C. It's not sensitive estradiol. And then again, like you said, you cannot start people off in the absence of symptoms. And how are they going to have symptoms if they're just initiating therapy?
Right. There's a lot of people we aren't talking about here tonight.
Yes.
Yeah.
Yes. Awesome, man. This is next level stuff. Go ahead, Josh.
So then at the end of the day, right, it's not the AI that's the issue. It's when it's not administered correctly. It's just the overall levels and the ratios. And that kind of leads us to the next topic, because we're always hearing about, we get asked this question on the show all the time. And I'm just the commentator of the show, not the expert. So I'm usually reading these and firing these off. But we always get asked, like, what is the level of estrogen I should be at? Like, what is the magic level for testosterone I should be at? And you hear all these different ratios and different levels. And, it just seems like there is no necessarily one size fits all. Everybody's a little different. We responds differently. But can you elaborate on that of
Sure.
not just the testosterone? Because so many guys are like, well, what's my test level should be? I've heard Jim and Jay, and correct me if I'm wrong, Jay, but talk about, look, I mean, your estrogen levels is just as important, if not more important than the test levels, and making sure that you get those right. But again, it's not some one size fits all, or is it?
Correct.
Exactly. Well, that's right. Some guys do great with a total testosterone of 400. Other guys got to be a little bit over the top for their right. That's just the way the body works. There's so many variables at play here. That's why we start low, go slow, and then build up over time. Ratios have a place in interventional endocrinology, in my opinion, in some places. To me, they have a place where the two hormones that you're comparing directly oppose each other. For instance, free T3 thyroid, ratio to reverse T3, somewhere around 20 should be the ratio. So you need more free T3 than reverse T3, because reverse T3 directly blocks T3. Talking about thyroid optimization now, which is something I do for male and female patients as well. Not only does that happen, but also when reverse T3 goes up, and I do test that sometimes, because your T3 can look very good and the patient's having a lot of stress. You can look at the reverse T3 and that's high. The reverse T3 is blocking the T3. Well, it's also diverting T4 from being converted in T3 and converting into more reverse T3. And so it's a double whammy on the body. So sometimes we add a little more cytomel in there, a little more T3 or in there in order to combat, to increase that ratio a little bit. Or in female patients, the progesterone estrogen ratio can be important in your clinical outcome. But this thing about a ratio between testosterone and estrogen, I really don't believe is true, because you can raise your testosterone to any level you want. And if your estrogen is too high or is wrong for you,
right,
then you're not going to feel right. So there's no magic number. But the way that we can use a testosterone-estrogen ratio is to explain a clinical symptom. In other words, if you say your testosterone is low, but your estrogen is mid-range or higher, you're estrogen dominant, and that's never going to feel good to a guy.
No.
So we can use them as one piece of the puzzle, but it's not a treatment goal, because they don't directly oppose each other in the same way that, for instance, T3 and reverse T3 do. So I think that's where ratios are useful, but we're not shooting for some ratio, because first place, we don't know what testosterone and estrogen levels can bring for that guy. Everybody's individual. They have their own little sweet spot along the way for each one of their hormones. Getting into that sweet spot is what the art is about.
Great answer. And Jim can't be here today, and he wanted to be here to talk to you because he wanted to ask you this question. So I'm going to ask for him, but he's at Disneyland with his family. So if he's watching, what's up, Jim? Because we asked Dr. Rob and we asked Meryl the same question. So we want your answer too. And you guys are probably all going to give a different answer, and I think it's actually even more valuable that I'm asking you right now because of what you said about how bogus most of the testing is, because they're not getting liquid seed. But where is the cutoff of an estrogen level in liquid C sensitive where you say, even in the absence of symptoms, and maybe you say there isn't, but is there a cutoff due to a potential risk of tumor formation or cancers or anything like that, in your opinion?
I say that it's an invalid test. It's a blown assay. If he's at Quest in the range for sensitive estradiol, ultra-sensitive estradiol, I'm sorry, test code number 30289, it's supposed to go to 29. And the guy comes in at 76 and he doesn't have any symptoms. I know it's a runaway test. Every golfer shanks one in the woods from time to time.
Well, how often do you think that happens, John? I'm glad you said that. How often do you think that happens?
I see it every week in some patient.
Jesus, dude.
Yeah, laboratory testing, that's why it's just one piece of the puzzle, because it is not what you think it would be.
So what is a patient's right then if, they come to you and you say, dude, I'm really sorry, but you got to get this done again? I mean, can you call the lab and say, I'm sorry, but this isn't right. This person has no symptoms, and you guys said that he does.
We just write another order and send them back in. As simple as that. If they've run the wrong test, that's a different matter. They've got the right one coming, but the laboratory will still make me write another order to cover up for their incompetence.
But I mean, does the patient have to pay for it?
If they've run the wrong test, the patient doesn't have to pay for it. They can make that claim. But if we really want to find out the issues, but you know what? If a guy feels great, he feels great.
Exactly.
And it's not broke anymore, so there's nothing to tinker with. So
this is important, man. I'm glad we just brought this up, because this is something that you see on the Excel Mail Place forum, and then obviously in the Facebook group. And you're seeing this all the time with you. And Josh, this stands to reason. I mean, so you just really said something important, and that is, the truth is, and I didn't even think of that, if you got somebody that has a 121 score on a sensitive liquid C, the test is blown, right? I mean, it's impossible.
No doubt.
Wow.
Or maybe he's a heavy alcoholic because they don't produce testosterone. They're shunting through androstenedione right to estrone. And so that can happen too, where they're losing the hair off their legs, their liver is failing, and so forth. Those guys will have huge estrogen numbers. Sometimes I've seen that before. So
if a guy's on TOT and has been on TOT working with you for 10 years and you've had him balanced, and all of a sudden he comes in with no symptoms and he runs a standard test with you and he gets an 80, then you literally go back to them and say, you guys effed this up.
Well, I generally ask him during the office visit while I'm ordering the labs if he's having estrogen symptoms or not. The guy says, no, I don't bother running the test. There's just no reason. Most of the other guys said. Yeah, right. No sense in wasting the money in perfectly good blood.
Right. Well, let's talk, because we didn't bring it up, but let's talk, because I know you're very outspoken about this, and then we'll answer some questions, and we'll talk a little bit about Nasser in a second if you want. Polycythemia vera and obviously erythrocytosis in the mistakes. But I did want to get your intakes. I mean, obviously it's spelled out in the book. John helped me with that. It's very, very, very clear. Most physicians don't understand it. But what are your thoughts on physicians that don't understand it, who are constantly phlebotomizing dudes who don't need to be phlebotomized? What are their risks as far as running their ferritin and their iron too low?
Well, ferritin does a lot more for the body than just carry iron to make blood. It also has, the guy's iron gets low, especially in the women, if their hair is falling out, if they're having adrenal issues and you put them on some thyroid, some hydrocortisone, and they're having a lot of problems, a lot of time to check their iron. But it also is important for T3 conversion from the thyroid. You need iron in all different ways. Guys with low ferritin levels tend to have shortness of breath. And a lot of these guys too, if they have sleep apnea, COPD, or something like that, they sure don't need a low ferritin to go on top of it. I went to a lecture last year that my dear friend Dr. Neil Rouzier gave at 90 minutes that really changed my thinking about this, where he showed numerous studies that showed that testosterone replacement therapy has never caused a single heart attack or stroke. It never has. We've been doing this for 4 decades. There's no documented case of it actually happening. So if the blood gets too thick, though, guys a lot of times just don't feel good. And if you feel better by going down and doing some blood, please do. It's also a wonderful thing to do for other people, of course, and that's important. But the guys who live at altitude, I talked to a guy in Denver today, his hemoglobin runs naturally just over 18.
Right. Well,
so is everybody else there. We're not sending them all down to have their blood drawn. Right. People with sleep apnea, COPD, smokers, etc., their hemoglobin run a little high. And this guy's hematocrit ran a little high too, but that's because he's dehydrated. Hematocrit is simply the percentage of the blood, if you spin it in a centrifuge, is solid material. So his hematocrit came in at 53 or 54 or something like that. It's dehydrated for him. You look at his BUN to creatinine ratio, as long as he's not on a high protein diet or on creatinine, which seems to be none of my patients. If the BUN to creatinine ratio is 20 or higher, they're dehydrated in the normal population, not us lugheads or guys who take high protein and creatine that changes the ratios up. But anyways, but the guys, a lot of them are giving blood, and we find over time is they're not feeling right. They're giving blood regularly. I run a ferritin and find out, which is ferritin, by the way, is iron storage protein. Find out that their iron stores aren't very good. Yeah, keep in mind too that ferritin can be falsely elevated by inflammation. So we're always working to decrease inflammation so we can have a false profit in the ferritin of it. It could be higher than it actually is. So again, it's case by case basis, but we're seeing the guys really, if your hemoglobin is at 19 and your hematocrit's at 55, they're really not at increased risk because platelets are what cause the blood to clot.
Right.
Now, if you look in a lot of references, look at what polycythemia vera is, which is a deadly disease. It'll kill you about a year and a half, is that they have extremely high platelets. And those platelets get over 600, 700. They're going to clot when you don't want them to, and that's called a heart attack, stroke, pulmonary embolism, whatever. That's a whole different matter. This is erythrocytosis we see in testosterone because the testosterone stimulates the bone marrow to make red blood cells, which makes it actually the best treatment for anemia we've ever seen. Just like testosterone is so good for type 2 diabetics, but we don't prescribe it for type 2 diabetes. But by golly, we probably should be able to, because testosterone pushes sugar in the cells through at least 4 different mechanisms. And if it's done right, it's completely safe. So,
John, it blows my mind. And again, you guys, if you're watching this and you haven't picked up a copy of the book, John's a member of the science team in the book. He has there's a lot of his work in the book. It's definitely the best book that's ever been written on this subject matter in detailing erythrocytosis and the difference between polycythemia vera. Dr. Rob and John are all over it. I even have Dr. Neal's studies in there. But John, it's mind-blowing to me because even when I talk to Nelson, I go, and him and I do a bunch of great stuff together too. So many physicians still don't get it right. They still all refer to it as polycythemia vera. It's so commonly garden variety mispronounced. The term is not spoken correctly, and it scares me because how many patients are being, scared into oblivion and obviously over phlebotomized because physicians don't understand this.
Well, I've got to make sure they're not over phlebotomized, but it's okay to go down and do a procedure known as phlebotomy or donating blood for something that you don't need. That's okay. It helps others.
Right.
The problem comes in sometimes these guys are being seen by a hematologist. Their ferritin gets low. The hematologist goes nuts when you tell the guy to take iron. We do not control hemoglobin hematocrit through iron deprivation. That is not good for the body. You see microcytosis or small red blood cells then. Hematologists really have a difficult time with the fact while you're phlebotomizing them, is giving them iron, which they desperately need for the rest of the body as well.
So then when you're doing that, I like to go down and give blood every 90 days, right? Because I think that's about the max that you can do it where they invite you back. And, I've got a popular blood type and it's, just way to go out there and give back, right? Is with everything that you just said, is if you're just doing this in a way to donate blood, is there a too frequent, is every 90 days safe or what's too frequent that somebody should maybe be worried about this?
Well, it's an excellent point you bring up, Joshua, because, iron is generally bad for guys. That's why there's no iron in men's multivitamins. We have too much iron in us. So donating blood is a good thing for us. So we're talking about guys that are not on testosterone replacement therapy and do not have elevations in hemoglobin and hematocrit. So not going down because their doctor told them to. That iron basically rusts in the arteries and causes plaques and therefore heart attacks. So guys should not be using iron skillets too much. No iron in our multivitamins, already said. So it's a good thing generally for men to dump some iron. That's been shown in numerous studies, no question about that. So we want to be very clear to make that distinction. We're not talking now about guys who are on testosterone replacement therapy. But if they're going down regularly and donating blood, it's a good idea to check their ferritin. Make sure they do have enough iron. That ferritin gets down around 15 or so, they start really having problems from it. And also, when the ferritin gets below 100, some guys have a hard time with anxiety. The patients have anxiety, we try to get their iron up somewhere in the 100 to 150 range. Generally, I'm happy around 80 or 90. it's hard to get iron up. I tell them to get a heme bound or a protein bound iron. Tell them to take it a couple times a day with 500 milligrams of vitamin C at the same time to increase absorption. It's hard to get their iron up sometimes. But also, if they're having low iron, you always got to take a look. You always got to be wondering if maybe the guy's got a little bleed. So we send him in a stool sample and look for iron in the stool, because an occult or a hidden bleed in the stool is colon cancer until proven otherwise.
Right.
So that's something else we always have to look at. We're looking at the ferritin. We're looking at the H&H, hemoglobin hematocrit. We're looking at the RDW. The RDW tells us how fast they're making blood. Look at the size of red blood cells. There's a little bit to it. So.
Yeah, love it. You guys, we got some questions coming. You guys good with answering some questions here?
Yeah, absolutely.
Hit me.
All right. So this first question here, and I know that this is a tough one to ask because we already talked about people's ratios, it being, patient to patient there. But this is about females that are wanting to take, the technical term isn't TRT, I guess it'd be HRT for females, but any reasonable test, they say cypionate or enanthate, starting dose for a female that wants to start TOT?
Well, let me say that I use DHEA to elevate testosterone in females. And start at 5 milligrams twice a day. You can get it at the health food store. I've seen DHEA greatly increase libido in women. If you take too much DHEA in your woman, it converts to testosterone. If you take too much DHEA in your man, it converts to estrogen, even though the pathways look the same. Viva la différence, especially here on this Valentine's Day theme. So start at 5 milligrams twice a day, and I got to watch out for androgenicity, such as their skin might break out a little bit at first. If you take too much, women can sprout some hair. So start at 5 twice a day and work their way up. But DHEA is wonderful for women. I encourage them to try that. And with your doctor's supervision, you always have to say testosterone dosing in women is a whole different ballgame. So,
yeah, I mean, is it when you go down that path, is it just like really extreme examples that you'd actually prescribe testosterone to a woman without treating it in ways that you just talked about?
No, testosterone is good for women. If you think about it too, when they take birth control pills, they suppress the system. They cut their testosterone down. So while they may have more libido because I know they're more free to enjoy their romantic life, their libido can go down because they don't have the testosterone. So, but the dosing for women is very different for testosterone.
John, will you prescribe only creams or gels for women, or will you also do once a very small micro injection?
I personally have only used creams and gels with women.
Right, but you do know some of your friends now are, of course, doing once a month micro injections, and I've actually heard from some of the women that are doing
once a month.
Yeah, once a month. Yeah, once a month. Or actually, maybe I'm wrong. Maybe it's every other week. I don't know. It's such very, very small dose.
So we're starting the women out the same way we started out.
Anyway, I could be wrong.
It doesn't seem right. That doesn't seem right.
It could be weekly, but I thought it was every other week. But maybe you're right. It's probably weekly. Hope to God it's weekly. But anyway, the people that I've heard it, and it is a very good physician that's doing it, say they do really, really well.
They tend to have higher sexual buying globulin, so that could be okay, yeah.
All right. So the next question goes back to when you talk about alcoholics. So question is just I guess confirming what your statement was. So alcoholics will continue to lose their testosterone due to drinking.
Mm-hmm.
Absolutely.
Yeah, testosterone, alcohol is a very harsh drug, and we've forgotten that. We get used to drinking, we've forgotten that. Alcohol also ramps up aromatase, which is the enzyme that converts testosterone to estrogen. That's what we're hitting with the anastrozole. And so you'll see that if I have too much to drink, if I were to do such a thing, it would make my nipples sensitive. So it's there's no question that's converting estrogen more. Yep. It also causes inflammation of the liver, so your sexual binding globulin goes down, and it's just really, really hard on your body. So,
yeah, I remember when I first had my testosterone checked, and this is at 33 years old, I was like 311. And I asked Jay, I'm like, why is it so low? And he goes, well, one of the things, because my test was low, my estrogen was high, is he said, well, it could be due to alcohol consumption. Do you drink a lot? And at the time, I'd given up drinking. But several years before that, I used to drink enough to drown a fish. I'm like, say no more, makes sense.
That's better now, isn't
it? Yeah. Oh, yeah. Yep. Okay. So the next question is, so Joe is doing testosterone cypionate, 100 milligrams a week. And he's asking, is daily sub-Q then breaking that up into you with the half-life, the best overall protocol. And I know we've talked a lot about this of more frequent injections. So is that the best protocol?
Well, it's a lot of fiddling around with it. Compliance is going to be an issue there. Some guys want to do that. I guess it's okay. It just seems like I do my shots twice a week. I have a super high sexual binding globulin. I think because of all the anti-inflammatories that I take, supplements I take. But if a guy wants to take it, every other day or something, seems a little more reasonable. But man, I'm taking the time to do a shot every day. If a guy wants to, I'm fine with it. If you have really low sexual binding globulin, it can be better, but it is a lot to ask of a patient.
Yeah, I'm like you, John. Sometimes I'm two, but right now I'm every other day, Monday, Wednesday, Friday. I actually just have it so sequenced around my training. My fasting days are different. My training days, I eat, I take my shot. But yeah, Dr. Rob had a really good point about it. He called it the only person that's going to really comply, like you said, patient adherence is the most important thing, is just the type A maniac. The anal retentive person who wakes up every single morning and does whatever, and part of whatever is the injection, right? Yeah. Well, a lot of guys, too, they take a tiny bit of HCG with the testosterone, and it's the same thing, like literally 20 milligrams, 20 milligrams.
Yeah, it's a lot easier to take that water base through a 31-gauge needle. The
Exactly.
HCG, the best, there's no question, the best HCG is daily because we're trying to replace that luteinizing hormone. Exactly. So we're looking for a roughly physiologic or normal concentration in the body of the mimic of HCG, of luteinizing hormone, which is HCG. So daily, no question about it, daily HCG shots are the way to go if you want to do it the best. But you can do it twice a week. It's all a negotiation with the patient.
But then would you recommend to the extreme of that, no less than, because it has, a 4-day half-life or 3.5-day half-life, so no less than 2 a week, right?
Well, this is, again, kind of to the next level, but it has a lot, hormones have a lot more, there's a lot more to it than thinking about the half-life of the drugs.
Right.
The part of the information that's transmitted, and that's what hormones do, they transmit information around the body. It's the way I think about it. It's not just off or on. It's not just concentration. It's also the shape of the curve. So, for instance, when you're younger, your luteinizing hormone goes up and down much more rapidly. The interval becomes longer as you age and the body slows down. Entropy, or randomness, as I say, is part and parcel of youth.
Right.
So the more random your levels are. So just because you don't just give drugs at the half-life of the drug, you got to think about what the shape of the curve is, where the uptake of the drug is, and that can come from better from daily dosing or every other day dosing with some of these medications.
Yep, love it. So I think the alcoholism or lots of drinks sparked got a lot of people thinking here. So the next question is, when it comes to, I mean, I know you already talked about, but this, how does alcohol itself shut down or affect the T levels? And is there differentiation on the type of alcohol? Like, can I drink vodka and not beer? Right?
I don't know really on purpose. There's less calories in vodka, but guys tend to throw shots of vodka. And that's just really harsh on the liver. When there's a rapid acceleration, you get a lot more acetaldehyde production that way. And acetaldehyde, by the way, is a powerful carcinogen. So alcohol and cancer are definitely related, especially in women. Averaging more than one drink a day for a woman dramatically increases the risk of breast cancer. So, I go out with my friends and I got to find something to drink, and they don't have any good bottled water there. I find myself having to drink a diet. That's what's there to drink. Get the end of the night, my buddies have had 3 or 4 beers. We leave, we're all going home, and I haven't put 800 or 1,000 or 1,200 calories in me, and I'm just great for the next day. At that point, I just don't see the value in it that much really anymore. So.
Yeah.
Hey, Josh, let me ask this question real quick. And I'm sorry that I'm not seeing it. Thank God you are. Again, this interface on Facebook is retarded. I didn't see any of these questions. But James Breen asks a really good question. He says, is there a particular injection frequency that would move sex hormone binding globulin in a specific direction, up or down?
Well, androgens tend to lower sex hormone binding globulin. Estrogen, by the way, is a group of hormones. Estrogen is actually about 40 different hormones. Testosterone is a specific hormone. So the opposite of estrogen isn't testosterone. The opposite of estrogen is androgen. If your sexual binding globulin is higher, take a larger dose to get up over the top of it. But then we kind of want to split our doses anyways, especially if we're doing subcutaneously, because we want to put too much volume in there. But probably having smaller doses more frequently is better with respect to increasing estrogen as well. So I think probably that's the way to go.
Yeah,
If I'm understanding the question properly.
Yeah, I mean, he just basically said, is there a specific injection frequency, amount per week that's going to do anything from a sex hormone binding globulin in either direction? So if it's less, are you going to drop it? If it's more, are you going to increase it, or vice versa?
Yeah, if the dosing is larger, it has more effect on the sex hormone binding globulin, has more effect on aromatase, increasing estrogen. It causes higher excretion of testosterone into the urine, and also ramps up the aromatase. So. And also, ramps up the hemoglobin hematocrit. You're more likely to induce high hemoglobin hematocrit on larger doses less frequently than you are in small doses.
Love it. So next one is a question which I know that we're working on this, but if you guys thought about putting together, a pro-TOT physician list worldwide that can help with our listeners be able to locate a physician. And we always talk about the importance of working with a great physician to go through this, right? So many people go to their general practitioners, and it's like, look, that's like me going, I'm not going to go to my general practitioner if I need orthopedic surgery, right? Like, get that specialist that knows this. But, speaking with that, Dr. Crisler, I mean, and I know we'll get this at the end as well and have this all in the show notes. But those that are maybe listening that want to work with you, have a conversation with you, where are you located? What's the best way to reach you? And if people are out of state, is there still a chance to be able to work with you or your company?
Sure. My office is in Lansing, Michigan. If you come in one time, you become a full patient, and we can do what we want to respect to medications and lab work and so forth. I do a lot of consulting for the doctors, for guys line up, and I talk to them, and I talk to a doctor, and I can help direct their care like that. But that doctor has to write the prescriptions and the lab orders. So I also offer what I call an advice-only consult, where I spend 30 minutes one-on-one with the guy on the phone, go over his medical history, go over labs and so forth, and I can do usually a pretty good job of directing their care from here. Maybe they're already under the care of another doctor. A lot of times we can actually reduce their doses and get better results, and doctors never mind having drug doses reduced. Or some of you guys just seem to be doing it on their own okay, and then I can direct their care pretty well from here like that. If they need lab work done, I send them over to Nelson Virgil's Discounted Labs. They do a great job. The panel is really inexpensive.
All liquid
I can direct their care remotely through the advice line console. I got a lot of guys. We decided we had so many guys that were converting from the AOC, they go ahead and make the trip in, that we knock off the cost of the advice line consult from the full consultation as an upgrade to help them with travel expenses. They like that too. So I've had a lot of guys that have started out as AOCs and then decided to become full patients.
Yeah. Love it. All right. So James asked, if platelets remain steady, do you still have a cutoff point with the HG and HCT where you advise phlebotomy? Also, if HG and HCT and platelets are steady, what would be the significance of increasing RDW? So I don't know what any of those mean, but hopefully you guys picked up on the
hemoglobin and hematocrit, and then red blood cells. Or I'm sorry. Go ahead, John. Sorry.
Right. Well, it depends how he feels. If his hemoglobin's up around 19, that's probably okay. It gets around 20, it starts to get a little worrisome. Might as well send him down. The viscosity of the blood is definitely increasing then. And, the pipes are bigger, talking plumber's terms. The pipes are bigger because testosterone increases nitric oxide and relaxes the pipes. They get bigger. But so it's a thicker liquid going through there. And some guys feel their blood pressure going up, might feel a little tingly in the shower, go on down and donate blood then. RDW is basically red blood cells are released in the bloodstream in immature form, kind of the same way we release our children in this society. And they have to mature on the fly. And so an RDW is the width of distribution of the red blood cells. Where they look at it under a microscope. In the microscope, the computer measures how many of them are young compared to how many are old, and you can tell how fast you're making blood that way. If the RDW is elevated, that means that there are a lot more young cells than there ought to be. It means making blood really fast. It's usually a sign of a bleed, or their androgen load is very high, so they're making blood really, really fast. So looking at the RDW is an important part of evaluating the CBC as well.
So another good question. And again, guys, first off, this has been an absolutely, and I've done a lot of podcasts with John, and this is amazing. I mean, this is definitely going to stand for a long time. There's been a lot of questions.
You got a better moderator, man.
Yeah, but no, I mean, I'm glad John, John talked really, really openly about AIs and stuff like that. And that really hasn't been brought out there because clearly we're of the stance that, that too many docs are overprescribing AIs. But John's point is an AI when there's a clinical need, when it's actually the right blood measurement level being evaluated is okay. And that's a huge hang your hat on in this show. But so John Corticelli asked a good question.
Well, but I was going to say my issue now is that there's a movement in our industry to not use aromatase inhibitors. They're spoken of at the conferences now like they're toxic or something like that. Right. And I think that needs some reevaluation by some really smart doctors. It really surprises me. Well,
I mean, I think you and me and Jim and us need to be at the forefront of saying, look, guys, if the test isn't liquid C, it's bogus. Mm-hmm. So, I mean, if that's what you're evaluating, guys' levels of estrogen by, it doesn't even mean anything. It's meaningless. But I want you to answer this question. It's a good question. He says, I take HCG and I really feel like my water, I fill up with water. I'm not on an AI. He's been on testosterone. We know this guy, John Corticelli. He's completely dialed in. He looks amazing. He's 52. He looks amazing. He takes care of himself. But he's like, every time I go on HCG, I just fill up with water. I definitely am increasing estrogen production. What can I do, John?
Did he mention what his dosing is?
I'll ask him. John, what's your I know he's watching. What's your HCG dosage? So the answer is you would try just to lower his dosage or drop his frequency.
Yeah. I still have the napkin where the one and only Dr. Eugene Shippen wrote when we had lunch together in Orlando about 10 years ago, where he made a graph of increasing HCG dosing and the testosterone continues to rise and then it plateaus, but estrogen and progesterone keep going up. So there's only so many Leydig cells that you can produce testosterone with. For some strange reason, you overusing HCG produces more estrogen and progesterone. Progesterone is very feminizing in men, as is the estrogen. So and beyond that, though, they're for everything that's out there, there's someone that will react badly to it. There's just someone that's sensitive. There's people who can't touch a nickel without having their skin break out, for God's sake. So again, just got to play. I know you react very badly to them too, even low doses we've talked about. So it's just the way it is for some people, unfortunately.
Well, what would you then just ballpark standard? Would you say half it if that's what's happening?
Sure.
Would you just half first and then go even maybe quarter?
I'd make sure he's taking no more than 100 a day. Break it down. There's no question a higher dose of HCG increases aromatase activity as well. So
right.
But the old days, they used to.
You've always been big on that, though. The Crisler method. You were one of the first guys that said like you were always a minimum, an MED, a minimum effective dose guy on HCG because so many docs are like shotgunning that shit, and it's just like no.
Yeah, usual protocol from endocrinologists to. By the way, the comment about the primary care physicians earlier. Most of the top thought leaders in our field are not endocrinologists; they're primary care doctors.
Right.
So I think that's because we tend to live with the families more than doctors who tend to just work out the ink on a piece of laboratory printout. But the dosing of the HCG just keep lowering it down. The endocrinologists used to give us regularly 5,000 a couple times a week or so. I learned this from the steroid guys because the steroid guys I could see that system was shut down and I started the old days. I've never prescribed a steroid, but I've used to do a lot more PCT and so forth, guys, and try to keep them healthy along the way till they quit taking steroids. But I started using low dose on these guys to replace that luteinizing hormone. And basically to a man, they told me they felt better. Yeah. I knew there was something to that. So that's why I just applied it to testosterone replacement therapy when I started working more in that area.
So let me just say this real quick because I think we got to the end. If you guys have another question, are you okay to answer a couple more questions, John?
Sure.
If you guys have any more questions, please put them out there. But again,
we do have a few in here, Jay.
Okay, go ahead. Hold on one second. Let me just put this out there, Josh, to ask the questions. You guys, Dr. John is really a good person. He will, they're very affordable. Like, look at your labs. Correct your excuse me, I didn't say that. Correct your doctor who doesn't have the experience necessary because John hasn't trained him to fix. So consider going to his website, booking a consultation. I'm telling you, it's not expensive. It's very affordable. If you're a blue-collar guy and you're watching the show, you can afford it, okay? Your health is too important, guys. Again, we say this forever. What is more important than your health? Like Josh says, and Dr. Rob made an amazing comment last week, and I agree 100%. Or 2 weeks ago, and Meryl agreed with it. If you cannot afford to spend $3,000 a year on optimizing your physical health, then your priorities are completely whacked. That's it. It's that simple. Like Josh always says, I mean, cut out a freaking fat ass, Starbucks $5 latte that you take every day that you ram through to stay awake in the afternoon. I mean, it's very simple. So anyway, consider, if your doctor's not good, working with John to get him trained. That simple. Go ahead, Josh. Ask this question.
Yeah. All right. So the next question is, again, I think the alcohol thing, kind of spooked a few people. So, which I get because it's such a big part of our social lives for a lot of people. But this next question is actually about marijuana. Can marijuana consumption impact hormone levels just like alcohol does?
Yeah, actually, it acts like an estrogen. That's pretty well established. It actually binds the estrogen receptor. So, I've seen potheads with gynecomastia or male breast development.
Right.
Yep. Cool. Back to the alcohol thing. This isn't about test levels, but does alcohol raise your triglycerides in your, I'm assuming they meant gut biome?
Yep.
Absolutely. Simple as that.
All right. So then currently on 2 shots, 45 units a week, which I don't know necessarily what that translates to dosage-wise, but then half of our 0.5 C in anastrozole Monday, Wednesday, Friday, and 25 milligrams Clomid Tuesday and Thursday. I feel like shit. After reading the TOT and then being here, I believe I'm taking too much AI. Is that true?
Sure sounds like it.
Yeah. Yeah.
I'd like to see the labs on that, but sure, it's only proper evaluation, but sure.
There you go, Dave. You know how to reach him, man. You know how to reach Dr. John now. You can get corrected. Don't waste time. Get it done.
All right. There was another one in here, but I lost. Does anastrozole lower estrogen in other ways besides inhibiting aromatase?
Not to my knowledge, but there are 2 pathways that make estrogen: androstenedione-estrone,
right,
and testosterone-estradiol. And there is an interconnectivity between the estradiol, the E2, and the estrone, E1. And part of what we do is to push things towards E1, because estrone pathway then is how we can metabolize it, break it down, and get rid of it. So vitamin D and basically the things that are good for you push from estradiol back to estrone, because it goes back and forth. So you want to move things towards estrone. That's where you get in the pathways. I use DIM. I use 100 milligrams of DIM a couple times a day, for instance. And cruciferous vegetables are great, especially for women, in order to reduce breast cancer risk. So I was using calcium D-glucarate before, but getting an extra few hundred milligrams of calcium a day, you got to think about that being laid down your coronary arteries. So especially if you're eating Greek yogurt or cottage cheese or anything like that on a regular basis, cheese on a regular basis. So I got to think about getting too much calcium. So I dropped the calcium D-glucarate. But
by the way, what would you say, this is just a question for me, this is a good question that we get all the time. From a detoxification standpoint, from an oral supplement, would you say that NAC is still the tried and true best to prevent any kind of liver toxicity from just living in these goddamn cesspools that we live in today?
Yeah, I use it a couple times a day. It converts to glutathione. It's great for your liver, no question about it. I'd recommend it for everyone.
What would your dosage be? Wait a minute. I think it's in the book. Buy the book.
Yeah. Love it. Well, that's the last question I see there. And Jay, I don't know if you wanted to lead into Dr. Nasser. And if so, I'll let you lead that because I live in a cave, so I haven't watched.
Yeah, no, if you want to talk about it real quick, John, I think it's good. It's good TV. Are you okay to talk about it for a minute?
Well, being part of the sparring community, it's just amazing how this one individual has infected and infested everything. Fortunately, brought to light how we need to be watching everywhere for this stuff going on. All these poor young women who had their lives permanently changed. The problem with pedophilia is that it makes them feel weird for the rest of their lives. It also short circuits the natural evolution of their romantic life, where you're holding hands and then getting your first kiss and so forth.
Right.
It's just dreadful. It's the most horrible crime. Dr. Larry Nassar was my first clinical professor. At the medical school, he came in on, I think it was Friday afternoons for a year with him. We had 6 students in the class, and I tell you, we just loved him. He's a great doctor. He's known as the king of ankles. as he's repaired ankles around the world, and that's really what he became famous for. But he come in and be so high energy, and he was so positive, and he was such a good teacher. I mean, he taught me how to do physical examinations. And then this whole thing comes down, and I, like a bunch of my colleagues here in the community, just didn't believe it at first.
Of course.
It couldn't be Larry. It couldn't be. And all these people, it just couldn't be. But as it goes on, there's no question about it now. And we're just absolutely sickened by it. And then it's just a creepy thought that you're ever in the same room with a guy. And I was his student in 1997. He was already doing this stuff in 1997. So while he was doing that, we were really enjoying his company in a class.
Right.
It's just another way that it hurts the community. And nothing like those poor young ladies whose lives he's ruined. But a few facts came out as we go along. We started to wake up, realize that these creeps are walking amongst us.
Right.
So that's the take-home lesson there. We have to always watch that our young people are being protected, and for people to look the other way, that is a need to report situation. That's the way for a physician. That is need to report situation is a law, is administrative law. But, you would never. These techniques that he do exist, I've been told, by osteopathic manipulative therapists. I've never seen them done. I've never done them because I don't work in that area of medicine. But not everyone would need that. You would always use a glove. You would always make sure there's consent. You'd always make sure there's a female or an adult in the room for the other patient. You wouldn't be doing it in someone's cabin, for gosh sakes. I just don't know how this guy was able to act and act out this way for so many years without being stopped. But we are just absolutely sickened by it, and I just feel really creepy the fact that I spend a year in the same room with him. It's really hard on everybody. Nothing like the survivors, of course. It's just dreadful.
I'm glad you shared your thoughts. It's mind blowing to me. I remember when I read the first article about a month ago when it first started circulating. But it's always the question you always have is, again, like I said, where were the fathers? Where were the brothers? I mean, this guy should have been, vigilante justice. Something should have happened. It blows my mind that this went on for so long and nothing was done. Because, John, I agree with you. And I can completely, and again, I'm not supporting a person like this, but I can understand when you know them in a professional capacity, why you just doubt. Your instant, no.
Well, we have rotten judges who purposely violate constitutional rights. We have rotten lawyers that sell out their clients and set them up the prosecutor and steal money from them and so forth. I mean, there are bad people everywhere. But these guys, he's a supreme manipulator. He was able to pull this off because he's such a good manipulator as he manipulated all those poor young ladies. Sometimes the parent was in the room at the same time all this stuff was going on. It's just I just don't know what he was thinking. It's just
so he was obviously brilliant.
He's really good at what he does. Even the god awful horrible things, obviously.
Yeah.
Getting away with being a terrible manipulator. So hundreds of young women.
Man, I know it's horrible, man. Well, John, thank you so much for coming on today and sharing this with us. I mean, this was obviously, this kind of lowered where we were, but I'm glad you spoke about it because it is good to speak about it, and hopefully it made you feel a little bit better. Definitely to hear it from you, it kind of humanizes it. For sure. But again, this was an amazing podcast. Again, you guys, if you want to work with Dr. John, evaluation or as a patient, you have to fly in one time, but he can definitely help you train your doctor and teach you. It's drjohncrisler.com. Just follow the instructions, get to his website. Do you want to say anything final thoughts, Josh?
Yeah, those that are watching and listening, as always, we truly appreciate you being here. Make sure to continue tuning in. This podcast exists to bring you guys the right information to level up in your health, fitness, and just overall life. And we do everything that we can to bring in the right experts so you can get the right information. Also below, right, will be all Dr. Crisler's contact information. And as he said, right, I mean, maybe you're working with a local physician. Maybe you don't have the funds or the ability to be able to fly out to Michigan, but he offers other consults and other ways that you can go out there and have access to him and still get his help. Hopefully you're able to fly out there. But just in case if you're in a position where you can't, or out of the country, I mean, we have so many people that are out of the country, right, that listen to this podcast. That consulting option he offers is absolutely amazing. And this guy's been doing this for several decades. One of the best, if not the best dude in the space at what he does. So it's so critical to make sure that you're getting the right aid and the right guidance is, you know, if you're watching this podcast, you hear us talk about religiously. So Dr. Crisler, this is an absolute honor, especially, and we know it's Valentine's Day, you taking time away from your family and you're busy to be here, man. This has been a huge honor.
Honor to serve you all.
Thanks, John.
Yeah. Thanks again, guys. Yep. We will see you next time.